Yeah, hi everybody. I just wanted to turn up the sound a little bit here. I just wanted to make sure I got this recording in. It's not very long. Just wants to finish up the anatomy of the urinary tract. We'll try to do it before my dog or my cat decide to have an interlude, which could happen very, very soon. So here we are. This is kind of where we left off with lecture on Wednesday. Again, there are two kinds of, and they have, and we'll get to their functionality, but principally, the vast majority of the nephrons are these. Everything takes place in the cortex. This is where most of the material is absorbed and secreted, with the exception of water. There's a minimal amount because most of the water exchange occurs here. I mean, just anatomically, there's a lot less water exchange that occurs here in these cortical nephrons, as opposed to these juxtamedullary nephrons, which basically means next to the medulla, those pyramidal areas, and this is really right in the pyramidal area, and these long, long loops of Henle or nephron loops, as they call them, and either term is perfectly acceptable. They're really designed for what it sets up something that's really important about how we concentrate the urine. That's very much physiology, and it's very much difficult physiology, and it comes to the end of next term. So you can see the location here and here, ones that are deep inside, ones that are occurring out there. That's where we were. Anatomically, these are called peritubular, around the tube, capillaries, and these are vasorecta for straight vessels. That's all. And those are the significant anatomical differences. We'll get to the physiology down the road. So, a key area in both of these that plays a pivotal role in controlling, particularly blood pressure. And blood pressure, basically, it's about fluid more than ultimately. I know there's other matters that occur in there when we get to the blood vessels themselves, but it's about the fluid. If we want to lower our blood pressure, we get rid of fluid. If we want to increase it for whatever reason, we hold in fluid, and we go through various times where we need to retain fluid or need to get rid of fluid. So this is the primary control, and it controls itself for the most part. It's called the juxta for next to glomerular complex, and they use the JGC acronym. And this is what I meant in the illustrations. You got to remember, if you go back and look, it's a lot more like this, where the structures are packed close together as opposed to being pulled up and being apart. They basically did that for demonstration purposes. So the distal part, I mean the end of the ascending limb of the nephron loop, and sometimes in contact, particularly with the afferent or incoming arteriole. And this is really about the filtrate formation. Again, the more filtrate we make, the more fluid we're going to get rid of. The less filtrate, the less fluid. The longer it's in the area, the more filtrate. The longer it's in the glomerulus, the more filtrate. The quicker it goes through, the less filtrate. That's a really simplistic way, but it works. Understand what goes on in the kidney. There are 3 cells that are part of this: the macula densa, and these are the ones that have chemoreceptors. Okay. So remember, we had a macula lutea. Don't get confused about it. Lutea generally implies a yellowish color. So densely packed area of these cells that are chemosensors for salt. Granular cells, juxta again, for glomerular cells, smooth muscle cells of the arteriole, and they're mechanical receptors. And they sense blood pressure, and they secrete this very important chemical called renin, renin. It's part of a really important mechanism to begin to understand that it's going to play a role in respiratory, it's going to play a role in kidney, it's going to play a role in blood pressure, all of these things. It's called the renin-angiotensin-aldosterone mechanism. Really super important. We get to that in physiology. And then we have the mesangial cells between them. Okay. And they are the ones that, and they say, and we use a permissive term in even a PowerPoint or in a reading that you have. It means this is the likely thing that it does. So they're not part of the glomerulus, and they basically are messenger cells between them, sending signals. And so this is a very good look, and this is something you'll be labeling anatomically for sure. So here it is. Here typically is this ascending limb, or of the nephron loop, typically where it's found. See the proximity now to both arterioles. This is the afferent because the afferent's always wider. This is the efferent, and the arrows are there. And this is a really good, diagram. Here's Bowman's capsule. Here's the start of the proximal convoluted tubule. And here you can see the capillaries. You can see basically the way that these cells with all these, what they call parasites, or podocytes rather, these little foot-like processes can open and close little clefts that'll allow more fluid or less fluid because the capillaries, remember, are fenestrated. They're there. That's the individual cells themselves. It's fascinating, okay, how that kidney works, and it works so well. Here are the macula densa. Here are the JG or granular cells, and these are the ones that secrete the renin. And here are the extraglomerular, means outside the glomerulus, mesangial or messaging cells, a good way, I think, to remember it. And so basically what happens, it senses concentration. These also sense pressure. And when necessary, they secrete this chemical renin. Renin immediately gets in the bloodstream, and eventually it's going to activate a really important chemical called angiotensin. The name tells you what it does. Angio is blood vessels. Tensin is increased tension. Our blood pressure is all about the tension in the blood vessels, how taut or how narrow or how wide they are. And that's based on how taut or tense they are, how the smooth muscles that we learned about already, whether they're a lot of them and they're being somewhat stimulated or they're being minimally stimulated. It's all about the degree of stimulation. Our blood pressure ultimately is the tension in those blood vessels. Are they a flexible tube? Are they a very stiff tube, etc.? That's really what it's about. And so then we lead into physiology. So for the time being, that's what you're going to really have to know. You can see, again, you can see the little filtration slits and the podocytes that are here. They can open and close those slits. And then underneath these podocytes, you can see these tiny pores. So it's always going to filter. The question is, are there openings there or are there not for the filtrate, for the liquid to escape? And I mean, that's an actual micrograph of it. So you can see how accurate or interesting it is based on that diagram. And this gets into the physiologies, and we're not going to talk, and these are the pressure, and we're going to get all into that. You can imagine how much fun we're going to have toward the end when we talk about all of the mechanisms that are there. There's a lot here. This is the main mechanism for blood pressure. We'll get into this, and effectively, just to take the short shift about it, here's the renin-angiotensin mechanism that's there. And this is why it all plays a role in different systems. It's released, it activates a precursor chemical called angiotensinogen. We'll get to that. And it activates it eventually in angiotensin 1 and angiotensin 2. We'll get into all of that. And then all the different things that it does. Oh, you're just going to love it. But it's a mechanism we see in 4 different areas. We see it in blood pressure, we see it in respiratory, we see it in kidney. Because part of where this becomes active is actually in the lung. That's why it's important. I see you, Pooch. He's getting up there. And we'll get into all of that stuff. And that's it. And when people are not having a lot of output, then you have real significant problems. Potentially they're in renal failure. All of these things are part of it that are there. It's very, very interesting. So we're done with that. Almost done with this whole little mini presentation. Not a lot to tell you about it. And so we'll complete that. And then I'm staying in the call. I forgot to adjust that stupid thing. Thank goodness that was true, because I would have had a kitty. Oh, I have to readjust these kids. Why? I have to readjust this. There it is. Every time you do an update, that happens. So hopefully this will stay. Which now we get to effectively, and this is basically the other anatomical part. This is in PowerPoint B. It's just more physiology and a lot. Most of this chapter is particularly physiology. I think the anatomy is a little less complicated, other than understanding the juxtamedullary nephrons and the cortical nephrons and the basic anatomy of the pyramids and things in the flow. So this is the other anatomy. Oops. We're getting here. Oh, here we are. Ureters. So effectively, you remember going back, that renal pelvis is really just a giant funnel, and it's and the cone of the funnel is the pelvis, and the tube that extends the stem of the funnel are the ureters on either side. And there's a continuation of the renal pelvis. Again, they're retroperitoneal, and they enter the posterior back of the bladder. So think of the bladder as a sac, and it's entering from the back, one on each side, and it's exiting right below it, almost creating a triangle. And you'll see that's very important. So as the bladder increases, your bladder increases, basically the pressure is enough to close those ureters, and so effectively the urine doesn't backflow into the ureters that are there. And as the pressure builds up, as we all know, you're going to have the sense you have to urinate. This is interesting, and it's important, because remember, this is where my cancer thankfully was, as opposed to is, or is, if there's any that's still there, hopefully not. The lining is transitional epithelia. It's really important. It's transitional because of its appearance. Again, transitional epithelium, if you go back and look at that chapter, which is chapter 4, with all the different tissues and stuff like that. Transitional epithelia are anywhere from as little as 2 or 3 layers to maybe 8 to 12 layers anatomically. And what distinctive, when the bladder's full, they're squished down. So it looks like 2 to 3 layers. Okay. And it's more of an appearance. It isn't that there are 2 to 3 layers. There are apparently 2 to 3 layers. When you empty the bladder, it looks like 8 to 12 layers. And the unique thing about it, what distinguishes it from stratified squamous, non-keratinizing, yes, you're going to see the nucleus, it's living tissue as opposed to the skin, but it has a rounded kind of appearance. The outermost layer, you can see they're almost rounded. They're definitely not flattened like squamous cells that you would see in stratified squamous, non-keratinizing. You have smooth muscle and sheets that are there. And again, you have to be, there's peristalsis, it's definitely smooth muscle. We'll go into the name of the muscle, and it's about how the urine formation is. Again, it's stretch receptors that do it. And again, you have both sympathetic and parasympathetic, which we're going to get to. But that innervation is more about controlling flow and urgency to go, as opposed to the peristalsis, which again is mostly stretch receptors. And again, it's not designed to move, so it's a dry lining we call adventitious. But the big players are transitional epithelia. This is the ureter. Go back and look at the esophagus. It almost is identical in its appearance. It's got the ability to expand. It's that fan folding thing. When it's like this, so it can expand, and when it expands, little particles can get trapped. That's where we see kidney stones, mostly in the bladder. They're not in the kidney, not, I beg your pardon, mostly in the ureter, not in the bladder or in the kidney. So we sometimes will see bladder stones. That's different. They're irritating and occupy space. That's our dog had those. They were made of calcium oxalate and had to be on a special diet and all that stuff. That was nasty. Okay, but I do not know that human beings have that. I plead innocent. I don't know. But in here is where those little nooks and crannies, where these calcium, and it's mostly calcium. We call it the nidus, the core of a stone. Could be blood, could be bacteria. Frequently, it's calcium. That's why it's so much important to have calcium carbonate or oyster shell calcium. It's much less likely to form stones. You have to have the right type of calcium, as opposed to like calcium phosphate for bone, which would be bad in this type of thing. You kind of get the idea. So it's a very neat anatomical picture, and it demonstrates its expanse on it. Here are the stones. Magnesium uric acid, and it's something we do see. Gout can lead to stones like this, and it's extraordinarily painful. Yes, you could get it. Okay, when you say lithiasis, it's a little bit more of, the implication is chronic, would be the way I would describe it. That's really long-term significant complications. Don't have to know those names. Renal calculi would be a name to know. Most of the time they pass fairly uneventfully. Okay, but the amount of pain is becoming much more common in women. It used to be almost always men, middle years, as they began to develop. Maybe it was associated as the prostate started to thicken. They just seem to be more prone to it. Typically, we saw men 30 to 50, and because of the referred pain, in other words, yeah, that's an internal organ where it hurts all the way toward the end of the penis. Oh my God. And I would see people in the emergency room in tears. Oh, the pain was obscene. Trying to pass that stone, which was extremely important. And then lithotripsy came along again, similar to gallstones. You're shooting ultrasound waves, typically when people are immersed in a water bath because the water conducts the sound waves better. Okay, and you basically are breaking them into little tiny granules so they can pass more easily. All sorts of things. And hydration is the key. The bladder. So to complete the thought, the muscle layers are very similar, circular and then longitudinal in the ureter, a little bit different. The bladder's just a sac. That's what it is. I mean, it's just a storage vessel. Unfortunately, it has problems associated because the urine accumulates there, and a lot of times there's toxins and carcinogens, hence the smoking relationship. Whatever the carcinogens that we find in cigarette smoke, and there are many, they tend to accumulate in the urine. That's why there's extraordinarily high correlation between cigarette smoking and bladder cancer. It's not the only cause, certainly, but it's. I remember my urologist at the time, who was different than the one I use now, even though we're in the same group. He said, in every case, effectively save one, all of the bladder cancer cases he ever treated or operated on were all, you guessed it, cigarette smokers. So it's retroperitoneal on the floor of the pelvis, behind the pubic symphysis. Okay. In males, the prostate, because it surrounds that outflow of the bladder, the urethra is certainly significant. In the female, it's, as you can see, it's placed in front of and that's, you see the pressure that goes on. That's really why we have, when women are pregnant, they have so much, because it's anterior to the vagina and uterus, and as the baby develops, it begins to press down on the bladder, and that can change the frequency. And this is a key area where we see infections. Again, when it's empty, it has those ridges like the stomach, a rugae. When it's full, it starts to flatten out. The one area that's consistently flat is this triangular area called the trigone, which you must know, which is the inputs on either side for the ureters and the output for the urethra. And again, transitional epithelia. The detrusor is this thick muscle, and it's extraordinarily important. 3 layers of smooth muscle, inner and outer longitudinal layers with circular middle, which is a little unique and interesting. And then again, adventitia, which is designed not to move it around. And effectively, it's still covered with peritoneum. But the big player here is to understand the detrusor muscle, and to understand that really places yourself. When you have 3 layers of muscle, it's a lot of muscle. Muscle is a barrier. That's why, thankfully, because we caught mine early, the muscle had not been invaded. Once the muscle becomes invaded, now you're starting to compromise a major barrier, and that really alters the prognosis. I mean, it makes it much more severe. In the case, it's much more life-threatening. People succumb to bladder cancer if it's not treated properly and quickly. Thankfully, I was a little more on top of it, and eventually stopped smoking. Thank goodness for that. And moving on. So the name of the muscle is important, and so it's a big barrier. Mine was in the outer lining itself. And here's the trigone area, and the 2 entry points and the exit point. Okay. And so that's what they're describing there. Particularly, this is that flattened area. You can start to see the rugae here. You can see, and we'll go over this again in repro here. You can see the surround of the prostate that's there. Really important. We'll get into the urethra and the 3 different components. You'll see that again. And the female, again, and understand urinary tract infections are much more common in the female because of the short urethra. And and the proximity to the anogenital area and the urethra, all basically in almost the same location, there is a significant increase. It's easy for infections. The urethra is short, so you usually end up with cystitis or acute bladder infections, as opposed to the male, where it's much more often urethritis. We see things like chlamydia or trichomonas or gonorrhea, which we'll talk about because it's part of the female reproductive when we get into that. And so rugae are there when it's empty, has a moderately full bladder. You get an idea. Expands and rises with pressure, and it can hold, as you can see, the moderately full bladder is about 500 milliliters. I mean, typically, if you're going a lot, most of us, it's probably considerably like 200 to 300 milliliters, just a guess. But and this is, I mean, and you can hold more. It has a lot of capacity, and we test that a lot in the hospital because people a lot of times have problems with this as they get older, and it's a contributing factor. And they do what's called a urogram, where they do a quick ultrasonic scan on the lower abdomen after they void, after they urinate, and check to see what's left in there residually. It's a really important thing. If you're going to do something clinical, you'll learn about it. Done all the time. Hospitals do it, nursing homes, particularly because there's more problems than that. So, I mean, this can really be, and I'll have some anecdotes for that down the road. This is just dye. You can see the calyces that are there. They outline it very nicely in this. Here it is, and here's the bladder. So it's really done. And the urethra basically is the outflow tube. It, as you can see, it's pseudostratified columnar and basically it's making a transition. Transitional near the bladder, stratified squamous epithelium near the exit point, just like any opening, like a nose or a mouth, anally, vaginally, they're always the same. And in between, some pseudostratified columnar. But remember, the transitional is really the key to me, because the other place we really see it, transitional is the identifiable or the main thing that we see in the ureters, the bladder, and at least in the start of the urethra. So I think that's important. And then we have the sphincters, which just one that holds it involuntarily and just effectively we're releasing it. We release both of these. This one we don't have control over because when it's full, it tells us to release this one and go. And that's it. And then we'll get to the lengths that are there. Again, this one, only 3 to 4 centimeters. We're talking about less than 2 inches. Okay. And the proximity. And then in the male, you're going to see and we'll go over this again. You have the prostatic part, which is where it exits the bladder. It's surrounded by the prostate. The intermediate, where effectively it passes through what they call the urogenital diaphragm, effectively going from inside the peritoneal cavity through a membranous portion, which is that portion, and then to the exterior, which we call the spongy urethra, all the way to when it opens. And I think that's basically it. We'll go over all that stuff when the time comes. All right. That's what I have to share with you today, as I'm fond of saying when I record these. And thankfully, I'm sure everything got in and it's all recorded. And have a great Thanksgiving if you're listening to it prior to that. Bye bye.